Brilliant. In that case, thank you, Subodh. So welcome, everybody. I'm Anne Paul, Chief Executive of Doctors in Distress. This is a Doctors in Distress webinar specifically for foundation doctors and very kindly supported by the Wesleyan Foundation, who have been extraordinary supporters of Doctors in Distress. So thank you to them. Doctors in Distress was started in 2019, so before COVID, very specifically by Amanda, who's just said hello to everyone, whose story we're not going to rehearse now, but will possibly come up as the webinar continues. Doctors in Distress believes absolutely that people need space and time to talk. They're talking about your feelings and your experiences helps to process what particularly the medical profession has been going through, is going through, and regrettably will probably continue to go through for a long while yet. So I am not going to take a long time over this. Housekeeping is that we're using the chat function. If you've got anything to say, questions for the panelists, we'll be monitoring that, and we'll make sure that Subodh, who is going to chair the panel, will pick up on all of them. This webinar is being recorded, so if so participants will be able to get the recording afterwards and share it however widely. So I'm going to say welcome to Subodh, who is Professor Subodh Dave, who is one of our wonderful trustees. Thank you. But is also the Dean of the Royal College of Psychiatrists. And Subodh is going to introduce Brendan and Paul and take the conversation forward from here. Subodh, thank you so much.
Thank you, Anne. It's really a pleasure to be here today. And thank you to Brendan and Paul, particularly for being here. I'll introduce you both in a minute. Just to say a little bit about myself. So I'm a psychiatrist by background. I've done community psychiatry for most of my working life. But I trained as a liaison psychiatrist, and I'm back doing liaison psychiatry. And it's interesting working in an acute hospital. You really get to see the pressures that everybody faces, right from the emergency department to all the wards. And I think last 2 years in the pandemic have been especially stressful for many people. So that's really shone a spotlight on some of the issues that we're going to talk about. But for me, I think it's half my job has been in medical education, and I've been involved in teaching medical students at the University of Nottingham. And I think in that role, sadly, I've come across suicides of medical students. I've seen a lot of medical students, being affected by a range of mental illness. So it's been a part and parcel of my working life. And then what's been most difficult and distressing has been to see that people have not sought help and sometimes not disclosed problems till sadly it's very, very late. And so I guess the main aim of today's webinar, if you like, is to really think about what are the issues that doctors face, particularly when they are starting off their journey, which we know is a long journey as a doctor, training as a doctor. I think foundation training is the first step, and then that there are many, many, many more steps to go through. And yesterday I was following the Twitter conversation, and I think medical students who are applying for foundation training were already sounding a bit miffed off, so more on that from you, Brendan, I'm sure. So without further ado, I think let me introduce Brendan firstly. I think Brendan Sargent, who is a foundation trainee. You're an F2, Brendan, and you work in Liverpool. And you might tell us what specialty you're going to take in the future, but I'll ask you to come in first, and then I think Paul Polyvios, who is an anesthetist and has already been through his foundation training, but And so we'll be able to kind of reflect on his experiences of running a podcast on issues around stress, burnout, and mental illness amongst doctors. And we also have David Snelders, who's one of our facilitators from Doctors in Distress. And I think, David, hopefully we can dip into your expertise through the webinar. So thank you for being there. But over to you, Brendan, first. So why don't you begin by introducing yourself and telling us what's got you into thinking about doctors' well-being?
Thank you very much, Subodh. So yeah, my name's Brendan. I'm an FY2 doctor in Liverpool, currently on my GP placement. And my first interaction with Doctors in Distress was via the Northwest Foundation Forum, for which I'm part of the committee. And last year I helped to organise a conference with that forum. And our conference was themed and based around celebrating foundation doctors and exploring foundation doctors' futures. And the committee decided that it would be an important theme to have would be the mental well-being of junior doctors. And so as part of that, we explored talks and workshops pertaining to that, but also reaching out to charities who would be relevant to that theme. And so I came across Doctors in Distress and had conversations via email and was very struck by how supportive they were and how willing to be engaged with our conference they were. Was quite taken aback by it, really. And so they sent us a little message which was included in the conference, and we've kind of had some conversations and supported each other in small ways since then. Obviously financial contribution from the conference, and then that kind of was one element of starting my interest in the mental well-being and mental health of junior doctors. But I think it had started a long time before that in medical school, and then especially last year in my first year for foundation year 1. And I think that came about quite naturally, as it does for most people, through conversations with peers and friends, and the kind of unfortunately slow realization that these things, these conversations happen with everyone, and these experiences happen to everyone. And I think sometimes those conversations are kept aside, but it became apparent to me, especially in my latter years of medical school, as I was struggling with the responsibilities and the expectations. And then last year, those responsibilities and expectations in a paid role during a pandemic, I think it became apparent to me that a lot is expected of young doctors in the early stages of their careers, and it can be quite difficult for us to have conversations about that with our peers and with our seniors. So it strikes me that any form of conversation about that is a good thing, and structured conversations about that with peers and with seniors, especially in this sort of format, is definitely a good thing. So I was really happy to be invited by Doctors in Distress to kind of take part in this panel. And I am excited to learn more about what we can do for junior doctors, and as I think we all should be a part of that conversation.
Mm. Thanks, Brendan. I think you hit the nail on the head, I think, in terms of the importance of conversations and structured conversations, and us having the safe psychological space to have those conversations, but B, also kind of having the skill to have that conversation, I think, and it's not always easy to kind of have those conversations. So let's come back to that. But Paul, maybe you can introduce yourself as well, and then we can try and revisit that conversation around how do we begin to have such a conversation.
Sure. Hi, thank you, and thank you to Doctors in Distress for inviting me. My name's Paul. I am an anaesthetist in London. I'm a fellow. I qualified about 10 years ago. I'm also a podcaster, host the podcast The Doctor's View, and it was that which started this journey in a way. I interviewed Amandip regarding his experience with burnout, and that started this endless journey actually with burnout, and more and more people were coming forward and seeing more and more data as more and more studies are done, and just the impact and the scale of the problem, and also from personal experiences as well. Like Brendan was saying, there's been testing times in the recent year or so, especially with the pandemic, and you're noticing as time's going on, the more and more people you talk to, it's the little problems that we will face in the NHS as junior doctors that often go unnoticed, and it could be something very small, such as struggling to find car parking space. It's these little things that over time build up, and all these small stresses do accumulate to the point where people do have had enough, and it does accumulate into burnout. And seeing and hearing about just the devastating effects that it has made me want to try and explore a bit more, and seeing what we can do about it, which, whilst it's been very difficult to come up with an answer for that, and I think many people have tried, and I know this charity is trying its hardest to come up with that solution, I think we're getting closer and closer in terms of being able to at least try and bring it down to a level which is far more manageable. And yeah, it's just a case of continuing. So.
Thanks, Paul. So let me just go back a step from what you both have mentioned, Brendan and Paul. And I think, we live in a world where you wouldn't be able to allow to go onto a building site without a hard hat. I think the clear health and safety executive, regulations. Now, most people would know and appreciate that medicine is a profession where you will come across mortality and morbidity on a regular basis. That's what you sign up to, right, when you decide to study medicine. So it's, and yet there doesn't seem to be that hard hat equivalent, or is there? I think we kind of muddle through issues. How do you cope with mortality? How do you cope with morbidity? How do you cope with the stresses of work, the dynamics of working in teams, and all the changeovers that come, and there are a whole lot of stresses built in, right? I mean, you mentioned one of them, Paul, around car parking, but there seem to be so many different things, right? I mean, the on calls, the difficulty in planning your life because you don't know where you're going to be placed there. I mean, there's just so many different levels of stress, and I think most people, I should imagine, when I speak to members of the public, they don't appreciate that's the kind of difficulty that every junior doctor in the land has to go through. That they can't literally plan their life. They don't know where to stay. If you've got a partner or a child who needs the nursery, you can't plan all these things because it's so difficult. And that's just one of the stresses, and there are so many other stresses that are built in. And yet, where's the hard hat? I think where's that? What are your thoughts on that?
It's very, as you said, it's the things that people don't see. They know the immediate stresses. So, for example, the things that are obvious to a lot of people, and people that want to go into medicine, they know there's going to be death. They know there's going to be difficult times. They know they're going to have stressful on-calls. And in some respects, that's almost part of why people are endeared towards medicine, because they kind of want those challenges. But in people's minds, those things are manageable to a certain type of individual, and they tend to be those personalities that go towards that. But it's the little things that people cannot see, and it is the moving. I've moved places and moved homes more times than I care to remember. I think things have improved slightly now in terms of how where you can be placed in terms of your commuting and what have you. So it may not be such an impact as it once was, but it's still significant. And having to apply for a post without being a guarantee that you'll get it, You may, as you said, have a family somewhere where you want to be close to them. You may not get that post. You may be wanting to work in a certain area for specific reasons. You may not get that post. And there's always this level of uncertainty with medicine. Whilst you're always, I want to, for want of a better word, guarantee the job, because we're so short on doctors, and but at the same time, the way you go about that is not, there's a lot of uncertainty in terms of where you're going to be working, your path towards what you're going to do. You may not enjoy your specialty. You may, I left one specialty to pursue anesthetics for various reasons. All these things are small stresses, and it's the things people don't tell you about, things like exams. They are an incredibly stressful part of things. They're incredibly expensive. Childcare, for a lot of people, I've met doctors whose entire salary gets spent on childcare. They work literally to improve their CV, to get their numbers up so that they can apply for other jobs, but their entire salary goes towards childcare. We mentioned before, little things like car parking, and not even having a locker to put your stuff in when you go to change in theatre, leaving them on lockers and taking your bags around with you. It feels unacceptable to be in a profession where these things are actually a problem. You kind of expect that from any place of work, somewhere where you can at least put your things, or somewhere where you can at least park your car, or leave at a reasonable time, and all these things do accumulate. And not just that, but there's also, you've got those things as well as the stresses and pressures that we spoke about briefly before. So yeah. Thanks,
Paul. No, absolutely well articulated. And Brendan, do you think that, being a foundation trainee, I think I've spoken to many foundation trainees, and F1 is kind of said to be the most difficult year of your training. Is that right? Is that justified reputation that F1 year has got? And tell us about your experiences, and what do you think of that?
Yeah, well, I won't be able to comment on whether or not F1 is the hardest year, because it's the only full year I've had, I suppose. But you kind of asked the initial question of where's the hard hat. And I think, just building on what Paul has said, how do you create a hard hat for risks and dangers that are so ambiguous and nebulous and widespread and embedded into the culture of our careers? All of the examples that you've just run through, Paul, they build up, absolutely, like you say, but it's often can be difficult to identify all of those things and mitigate all of those things. And I think for institutions, where do you start? I think that's quite a difficult thing to do, which is why it's important that we're having these conversations in the first place. To your question about foundation year one, I think I could believe that it would be the hardest year, yes. And I think that might be because you're getting to grips with what your limits are and how you as an individual can balance all of these expectations and pressures. And I think that's, in my limited experience so far, is one of the most striking things for me, is that it's different for everyone. And that's really, really hard, because you can watch others take on loads, be really, really good at their job, and have extracurricular things going on, the CV building's going on, and you might see yourself not being able to keep that up, or if you are keeping that up, other things are suffering, your social life, or you're becoming anxious, or your mental health is suffering. And so I think FY1 is really, really hard for that reason, primarily, at least in my mind, primarily, because you're learning to balance all of these different things. You're expected to do this really difficult job and be confronted with morbidity and mortality properly for the first time. You'll have seen it in medical school, but the first time that you're faced with a serious clinical situation and you're on your own dealing with that is not something that anything can prepare you for. And then on top of that, the culture is so is set up on the idea of preparing you for future careers. And so how is my CV? What do I want to do? How do I need to angle myself towards that career? And there's no time during the day in a busy ward to do that. So that happens in the evening, and that happens in the weekends, and that happens in conversations with peers. And to what extent am I as an individual able to handle that and balance that took me, well, I can't use the past tense. I'm still getting to grips with that. And I think that's one of the hardest parts, is it's not only a difficult job, and it's not only you've got on calls and all of these different pressures and expectations, but you don't know how much of yourself you can give to any one aspect of this career. And then I don't think that there's much guidance on that. And maybe it's because because we don't know, and maybe it's because it's such an individual thing. How can you possibly give guidance on it? But I see a lot of people, myself included, who have thrown themselves into lots of things, doing audits or research or teaching and doing the job and thinking about future careers. And then a lot of people I know, myself included, have got to the stage of thinking, I'm overstretched. And I don't remember that being talked about much. I remember it being talked about on calls and death and dying and difficult clinical situations in medical school. But not many people spoke to me about have realistic expectations and accept that what you're doing is a difficult job, and that in and of itself is valuable. And you don't need to give yourself value based on all of these other things that you do, because I think that's quite easy to do.
That's an excellent point, Brendan. I think something that I've reflected on as well. I think I sometimes sit on committees where we give awards, and I'm absolutely blown away by the level of the competition, and people who've done PhDs and have then also written several publications, and they are still a core trainee, and stuff like that. And I think it just and often I've felt, I've thought that, well, I wish there was an award for an ordinary resident, core trainee, somebody who's just doing a good job, a good enough job. And I think as a psychiatrist, I think we really have this concept of good enough, and I think we talk about that. And I think we've probably lost sense of that in that pursuit of excellence, I think, which I think is important. But it's also important that, we have that work-life balance, because otherwise it's not sustainable. And I think that's what you're saying. And I think what I'm hearing now, I think, is that previously we used to see that burnout occurring later on in your career. So that pressure was building up. But I think it's come forward and forward and forward. And now, certainly, I think when I've followed the data from the NHS staff survey from 2016 onwards, so just pre-pandemic, I think obviously we saw a huge surge in the pandemic times, but this was building up before the pandemic. We started seeing increase in the rates of stress and burnout and mental illness amongst doctors well before the pandemic, and I think another figure that I kind of always make reference to, I think, is, as a psychiatrist, I've been part of campaigns where we talked about 1 in 4, and I think we had people like Stephen Fry front the campaign to kind of bring about the idea that, look, mental illness can affect anyone, and irrespective of whether you are, if you're well off or as famous as Stephen Fry is, you can still get mental illness. But I think that what the 1 in 4 figure hides is the fact that actually some people are more vulnerable. For them, it's worse than 1 in 4. And we often forget that for medics, it's actually worse than 1 in 4, that the risk is higher in medics. And I think that risk starts at medical student level, and as you both said, Paul and Brendan, I think obviously people sign up to it knowing that you will deal with mortality, morbidity, etc. But I'm not sure that everyone understands quite the difference that exists between the general population and medical students, and how much more vulnerable we are as a population. And I think because that sets in quite early, I think all the factors that you mentioned, and they start quite early, I think you probably see that there's a set of common traits that develop, I feel, in terms of how we talk about it and how we deal with it. And I think I wonder what your take is on this, because one of the phrases that has been in common parlance is around resilience, and I think there's been a lot around resilience training, and some of the curricula have started introducing that in the training programs. What do you think? Does that have a role to play? Do you feel that's helpful, or is it counterproductive? Who wants to go first? Brendan, go ahead.
Yeah, sure. I think resilience has a role to play, but I would be very afraid of putting resilience as the kind of key term and the key concept front and center. I think, again, in my limited experience with peers and friends who have found themselves in situations where their mental health they've been struggling with their mental health, again, that component of expectation and perception of what it is to be a doctor comes into play. And I think I've seen people presenting later than I think that they would have done otherwise if they were in a different career, because they have this sense of, I shouldn't be susceptible to this, or, oh, I'm just, I'm being melodramatic or something like that. And I think part of that is because we're bad at recognizing things in ourselves that we're very good at recognizing in others. And part of that is because, again, we're seeing other people doing well in the same situation as us. And so it's difficult to accept or concede that you are struggling. And, we're not having enough of a conversation on many levels about this sort of thing, so people don't realize how common it is. So I think that being the case, talking about resilience front and center puts a lot of emphasis on it being an individual needing to improve. And I think that would just exacerbate some of those problems that I've mentioned. Whereas we've already established that there are systemic problems that definitely are implicated in this. And so we can't talk about resilience without talking about changing these systemic problems. Because to say, okay, yes, we acknowledge that there are things at fault here in the system, but what we're going to do about that is try and help you be better, is just another pressure. And I think the irony of that I don't think that would help. It has a place. I think that's important to say, but again, yeah, I would shy away from using that as the kind of.
Thanks, Paul.
Yeah, I think echoing what Brendan's saying, there might be a role in that, but it's not the answer. I mean, you expect a certain amount of things when you go into medicine. It's like going into the army and being shocked that you're having to fire a gun. There's certain things that you expect, but in terms of resilience, I think people that get through 5 years of medical school, they're pretty resilient. They show a level of tenacity. It's not easy to keep doing that year after year, and just having someone or training to say you have to be more resilient, suck it up kind of situation, it's not going to be the most helpful of things, because whilst your expectations of a job that you're going into are at a certain level, when things start getting above that level and the workload that you're being given exceeds that level, and the things that are being demanded of you is constantly exceeding, not just once a week or once every couple of weeks, but on a daily basis, because there's not enough staff, there's not enough assistants. You have a difficulty in you want to do what's best for your patients, and you're struggling to be able to do that because you have to be in 5 places at once. And this was the thing that I noticed in maybe not so much F1, but even though I know it is a problem, but from my personal experience, it was later on that I started noticing as responsibility increased. When you weren't at that consultant level and you weren't at that very, very junior level, you were expected to sort things out. And there was almost like, I won't say a stigma attached to asking for help, but there was definitely, you had this fear of being seen as incompetent because you were phoning someone at 2 a.m, and there was this fear of waking someone up. And that depends department on department and where you work in terms of how approachable you think someone is. But at the same time, it should never really be an issue, and you shouldn't be putting this amount of pressure on juniors. So yeah, resilience, sure, but up to a certain point, and I don't think that training someone to be resilient is going to fix an issue of burnout. In fact, it will just exacerbate it even worse, in my opinion, because you end up someone thinking, I've had training, I should be even better at this. I shouldn't be feeling like this at all because I'm I've got a piece of paper saying that I'm resilient, so I'll look even more silly if I bring something up now. And
no, that's so true. And I think and I think that's the kind of feedback I've had broadly from most of the people I've spoken to. And Paul, you brought in the concept of stigma in relation to work. But I think, again, going back to the issue of systemic versus individual factors, I think stigma is an important issue, I feel, because we often talk about stigma, particularly on mental health issues. And I think, as a psychiatrist, I know that that's a real thing, because, people tend not to talk about it. And, I think the jokes about psychiatrists in itself kind of tells us the story of stigma, that both people with mental illness and psychiatrists have to face. But I think there's also another issue. I think the flip side of that is that the stigma persists because there's discrimination. I think, and I wonder what's your take on that. I think is as part of the reason why people don't disclose their problems or don't speak up or don't feel comfortable talking about stress, burnout, or mental illness at work, is because they fear that there will be real consequences to that. And certainly as a psychiatrist, I've seen discrimination working for my patients and for my colleagues who have mental illness. And I feel sometimes that, we kind of have campaigns against stigma, but I also feel that we really need to have campaigns against discrimination, because, what we really want to address is that people with real illnesses and real disability caused by those illnesses should not be facing discrimination at work. That's just not okay. What's your take on that, Paul? Maybe first, and then Brendan.
Yeah, I think I want to shed a little bit of good news in a way from my own personal experience. And yes, there is, of course, this stigma that people are fearing. From my experience, and I think this is one area where I feel, at least in the places where I have worked recently, has improved. And that is, support is actually available. And when you go past that initial, do you know what, I need help with something. I'm not, as in, I need help with, I'm not coping with something. It's amazing, actually, once that conversation is started, that there are people, maybe not everyone that works in a hospital at a senior level, but there are certainly people out there who will listen to you and will help you. And that's one thing which I found a surprise. It was something which, it was nice to know, actually. And one thing which I've mentioned to a lot of people before is, once you get over that initial, this is going to really harm my career, this is going to, and all these things that we bring ourselves, that we make ourselves scared of, actually, I found, and I was thinking about this, it may actually do you more harm not to say something, not just on a personal level, but actually from a career level. And what I mean by that is, suppose one day something happens and someone, you realize that you weren't performing at your best because you're suffering from be it depression or be it just burnout in its early stages, and it becomes something else, and something happens. It may or may not be because of that, but you'll always wonder yourself, and it will play on your mind, and it can impact negatively if people say, why did you not tell someone? We could have changed your on-calls, we could have put you on a different rota, and all these things. And what's been amazing to me is see how happy people are to do that when you actually speak to them. But the problem is that initial speaking to someone, and it's that initial getting over that fear that it's going to really bring you down. So all I'll say is, from my experience, it's not been a case of, oh, there's Paul, there's someone that suffered with burnout, or there's, so and so, oh yeah, that's the burnout doctor. That doesn't happen, actually. And in reality, people are very accommodating, and people are very sympathetic. And I found, this may be anecdotal, but I think the reason why people are so accommodating is because there's been a point where they felt the same, and a lot of people probably are feeling the same, and it's just so they can relate to it, and they're almost thinking, it almost is a cascade of things. When you say to someone, I'm feeling like this, you'll be amazed at the stories that they tell you, and just how empathetic they are with it. And so I think we do need to get over that fear. It doesn't harm you to say this, at least I believe.
Thanks, Paul. I think I share that optimism, because I think I also seen the same. I think I've seen more and more people coming in and talking about it, and conversations are certainly becoming a more commonplace, I think. Brendan, what's your view? I mean, is there still a hesitancy to speak up, seek help? And if so, what do you think is driving that?
Yeah, again, echo the optimism in many ways. I've seen friends and peers receive help, and I know that many of us were surprised last year at how understanding and generous the departments that we worked with, especially the foundation team, the seniors in the foundation team, were fantastic at helping those junior doctors who needed it. Be it with changes to rotas, or extra support, or more clinical input for their mental health, all of those things. And there were definitely routes available for them, and I thought that was fantastic. The thing that I have observed, though, was that those individuals had to seek that actively, and that was a difficult process for them. And it strikes me that, and this isn't just in my location, this is from speaking to friends, foundation doctors from across the UK, including Scotland, where I went to university, that often seniors aren't as proactive as they might be in checking in on people. And I don't know, I mean, maybe that's a difficult thing to balance, is how do you check in on people, on junior doctors as a senior? I'm not sure. I don't think I have the answer to that. But we do, as a foundation doctor, I have regular checks on my portfolio and regular checks on how I'm doing clinically. And those are structured, and there are expectations, and I receive contact about that proactively from a senior. And that same thing doesn't happen in regards to how I'm coping on a pastoral level or a mental health level. Now, nominally it does, and in some ways it does, but I don't think, in my experience, and in many of my, or most people I know experience, that happens on any kind of deep level. And that makes it harder to seek help, because you don't perceive that there is, or you don't perceive a normalization of those struggles, and you don't perceive that other people will expect you to have those struggles, and so you put it off. So the help is there when people seek it, but it's hard to seek it, and I think that will be difficult to change because of who doctors are as people, and because of the culture that we work in, and I think it'll take time to change that. And so I think a shorter term possibility would be that seniors can just be more proactive about checking in on people.
That's a great point, Brendan. I think it goes back to your earlier conversation around structured conversations. And I think just to share a brief anecdote, so I think about myself, I mean, so some point in the end of 2019, I think I'd suffered an ankle injury, so I was on crutches for some time. And I think the number of people who stopped me in the corridors, asked what happened, and people whom I didn't know very well also, stopped me, asked me what happened. And there was a clear sense of people being able to have that conversation quite easily. And just so happened, a few weeks later, I suffered 3 bereavements in quick succession, people whom I was close to. And so I just sent around an email to my team saying that it's been a difficult time, it's just one thing on top of the other. And out of a team of about 70, only 2 people kind of felt able to come back to me and have a check-in, like you said, with me. And I wonder whether there's an issue around people not feeling confident in how to have these conversations. And I think, at one level, it's just being human. I think we don't need to go on a course to ask someone else, how are you doing? And then do you want to have a cup of tea? We do this in our daily life. But yet, I think there's something that stops us, right, from having that very humane conversation when it's perceived to be somebody else's mental health rather than their physical health. And I think, when Paul, I saw you nodding there. What's your thought on that?
I wanted to say I actually think this is one of those things that can actually be solved very easily. In that when I started a job recently, I got to know the department very well, and the first thing when I sat down with my supervisor, we did the things that Brendan was talking about, your assessments, all these things that you do in terms of competence, and it was, how are you? Tell me, what are you okay? Are you happy? Is anything on your mind? And this was in the first week of meeting, and you got this rapport, and you develop these friendships in a way, and every now and then it's a case of, how's your day been? How's your week been? And you say, I've had actually been really bad. I had an awful day. I say, let's go for a coffee. Let's have a chat about it. And it's something that it's a shame that it has to be, that it's taken 11 years for someone to have asked me that in the NHS. But and I'd like to think that it's something that people will start doing as a supervisor, or as even just consultants in a department, just seeing juniors. And I don't know if it's part of a checklist or not, or in terms of the way they have to ask you so they can say that they've asked you, but I didn't feel it was part of a checklist. It felt, even if it felt like they genuinely cared about the answer rather than just asking for the sake of asking. And I think that's something, if that was just simply introduced, even be it as a checklist, if it has to be, as part of our portfolio, ask your trainee, how are they? Are they feeling down? Are they feeling it? Just even little leading questions, if that was part of the induction process. Now, the flip side to that is you're going to have trainees going, yeah, I'm fine. That's always going to be the flip side. But it may, if it was led up with, look, if they had a conversation saying, okay, you feel fine now. If at any point you don't, come see me. It's not going to be a problem. It'll be off the record. We'll just have a chat. I don't think that's a particularly difficult thing to do, but at the same time, the realities of things aren't always the same.
No, but we've got to make a start somewhere, isn't it? And I think, Brendan, does that chime with your idea of the structured conversation? Is that what you were alluding to?
Yeah, I think so. I mean, it's difficult because I think there's a part of me that wants to point out that seniors might be burnt out as well, and so it's difficult to kind of expect them to take the burden of somebody else's emotional distress on as well. So I completely agree with what Paul was saying. I feel uncomfortable with the idea of this being dependent on the goodwill of individuals, though. And I think until this is normalised across the NHS, I think it probably will be necessary for there to be some structure to it. So, I don't think anyone likes the idea of checklist being used for somebody's mental well-being, because it's probably not a good way of doing it. But just that, as Paul just said, as a starting point, and just, you know, encouraging people to use that as a starting point, as a platform to an open and honest conversation, I think is a good start. And then once we've normalized it, we can see where we're at. But at the moment, I don't see that it is ubiquitous or normal across the NHS.
No, I think I agree with you. I think I'm a great believer in kind of, while we were talking about systems, and there are a whole lot of systemic factors, I think it's also, I'm a great believer in that sense of empowerment. I do feel that a lot of us underestimate the power that we actually have in terms of making a difference, and how that simple, I think, Paul, like you, I've been in situations where that simple "how are you" has made all the difference. And I think we sometimes forget how much of a difference can that one phrase make, you know, and how much of a difference that one single offer of having a cup of tea with them can make, you know. And I think partly it's about us communicating with people that we actually do have the power of making a difference, you know. I mean, if you choose to exercise it, you know, I think, and then would you, you know, just have a think about exercising it, you know, it will, and I guess we do it naturally a lot of the times, but I agree with you, Brendan, that there is that compassion fatigue at times, and I think, you know, that there is a real issue around that. But if it kind of exists at the team level where we all kind of support ourselves in that, because it's a bit like in care, you know, person-centered care. We all want to be person-centered. We want to be focusing on our patients and take their individual beliefs, values, expectations into account. But we also know that we can't be like that each and every time. And when you're not, that's when you have that peer support, isn't it? And you try and have supervision to try and see what can you do. That's when that supervision kicks in, and you get some help. And I wonder whether one of the things, in some places, I mean, again, as a psychiatrist, I think I'll talk of balance groups or supervision groups. I think that they seem to have helped, you know. I think, and there's some evidence to show that helps, you know, which I think just kind of takes care of that compassion fatigue. I think where the team owns that rather than, again, putting it on an individual. I don't know whether you have any thoughts as we start thinking of kind of solutions.
It is difficult. It does put it's nice, and if the team could, if it could be an active process just as part of your everyday life, that the team looks out for each other. And I think actually in terms of how to deal with it, it almost feels that is the way forward, rather than pointing it to individuals. If everyone collectively does it. But I think part of the challenge in that is actually recognizing it and actually acknowledging that this is actually a problem and that it is something that people suffer from. A lot of people can relate to certain things, but it's acknowledging that that's actually a small thing that could lead to something bigger later on. And I like to think that we all in some way do support each other as a team, in terms of we do sort of debag, as it were, to our friends, to our colleagues when we have a bad day, or if we've had a difficult patient or a difficult encounter, we do talk about it. I think, be it in the canteen, be it in the doctor's mess, be it wherever it may be. So we do try and do that, but at the same time, it's picking up the subtlety, of when something becomes that next level, and when something needs to have further intervention. And I think that's where the difficulty is, and I don't know how we would go about doing that in a way.
Anne, you've got your hand up.
I have, because I think taking us to solutions, and before we end, I think it would be great if we just bring David in for a moment to tell us. David, I hope I'm not taking you by surprise there. Just introduce yourself and just say a little bit about the value of groups, and then I'll
certainly. Okay, so I'm a clinical counsellor that works with the ambulance service across the UK. So I take care of the mental health of paramedics, ambulance staff, wherever they are. but my speciality really is that trauma, that PTSD and suicidality. And very similar to yourselves, I think one of the things there is that they are sometimes frightened of saying too much to other people because they are seen to be maybe not be able to do their job. So there's a stigma around this kind of self-disclosure about mental health. There's also the other part where if people do start disclosing to their colleagues, etc., they're a little bit worried about actually how far does that conversation go, particularly in the inner circle itself. So the nice part about the things with like Doctors in Distress, etc., is because it's, should we say, independent, people have more, should we say, trust in going to an independent outside source to support. And I think this is where the group part of things helps, because people realize and understand that actually they're not going through it on their own, which is so important, that actually it's not unique to them, but actually to doctors in general, that people are going through the same type of distress and pressures and problems. And it might be that a couple of people in that group can help them to go through that by saying to them, well, actually, this is how I work. This is what I did.
Thanks, David. I mean, that's really helpful. And I think probably the word suicide hadn't really come up in conversation. So I think it's just a sobering reminder at the end that that's something that we need to bear in mind. And I think Doctors in Distress started with that Amandeep's story. I think those of you who are not familiar with that, please have a look on the website. And Paul, I believe you have a podcast that you might be able to share as well, that you've got with Amandeep.
Yes, that's where this journey actually started in a long while ago, a couple of years ago, and I did interview Amandeep, and he was very kind enough to be so candid about his story, and it was quite a powerful story in terms of hearing it for the first time in person. Had quite an effect, and so if anyone does want to listen to that interview, I'll put a link in the chat log.
That'd be great. Thank you so much. I think so. Yeah, I think I just wanted to bring it back to the origin of Doctors in Distress, and just remind people that every little actually does help. And I think each bit that you do, each conversation, as we've said, sometimes can set in chain a set of events that actually deflects people from that negative kind of end that sadly we've seen in some cases. So thank you all for your inputs today. I think Brendan, Paul, and David has been really very helpful. I think I've learned stuff from you both as well, and David, it's always great to hear the work that you're doing. It's fantastic. So with that, let me thank you both, and thank you, Anne, and the team here at Doctors in Distress, and I'll hand you over to you, Anne, to have the final words.
Because of course I have to have the final word, those who know me. The conversation you three have had, and then with you, David, and the chats has been so humbling, because just listening to you, being able to chat as if the three of you are in a room and sharing insights has enabled so many of us, and will enable, as we put it on all the various channels, people to understand that you're human like everybody else. Doctors have tough times. They have moments where they need help. I think, Paul, it was you who said people do like to be asked for help. I know there is still that stigma, as Brendan, you said, where you're not sure if your seniors are going to take it quite the way Paul has described. I think, Subodh, you talk about empowering. One of the problems may be that the medical profession is still very hierarchical, and there is either a real or maybe even a perceived worry that if I show my seniors that I am vulnerable, I am having a tough time, I'm not entirely sure that it's going to be taken in the right way. However, and I believe this so strongly, that every conversation, every act of kindness, every peer support that people ask for and get will be changing the system ever so slightly. And it's by not asking for help and by almost accepting the stigma that the status quo will remain. So as hard as it is, we have to accept that doctors are as vulnerable to mental illness, and slightly more so, but to stress and anxiety in so many different ways. And it is for us to be supporting each other and, of course, the whole profession. So I need to thank our three panelists and David as our super facilitator, because sharing how you feel about things isn't easy. Doctors in Distress is so blessed by having people who are willing to help and to share their stories. And to anybody who's listening to this, reach out to each other, but reach out. Doctors in Distress is here. There are loads of resources on our website. So just to say thank you from the bottom of my heart, thank you to all of you. And to Subodh for your continuing support as a trustee. Can I wish you all a good evening? It's pouring where I am, but I hope stay safe and we'll see you all again. Thank you again.